طيب بسم الله الرحمن الرحيم. Good evening everyone. I am Dr. Mohammed Al-Shamrani, pediatric ophthalmologist at King Saud University Medical City. On behalf of Saudi Ophthalmological Society, I want to welcome all of you to tonight's webinar. Before starting, I want to thank Novartis for sponsoring this webinar and to thank IQVIA HCB Space for providing the platform for this webinar. Tonight's webinar will be presented by Dr. Basamat Al-Muallim. Dr. Basamat is Assistant Professor and Consultant of Ophthalmic Genetist at Ophthalmology Department, King Saud University Medical City, King Saud University, Riyadh, Saudi Arabia. Her presentation today will be entitled Inherited Retinal Diseases, Challenges and Opportunities. Before leaving you, Dr. Basamat, I want to remind all of you to type your questions in the question and answer box in the screen. Dr. Basamat, you can start. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Dr. Mohammed, for the nice introduction. Thanks for the SOS and Novartis for organizing this webinar. Welcome all to the SOS webinar tonight, which will be entitled as Inherited Retinal Diseases, Challenges and Opportunities. As you know, inherited retinal diseases is a promising field for implementing precision medicine because of the eye's amenability to intervention and the significant human and economic burden it incurs. In this webinar, we'll try to tackle four main objectives, starting with the general clinical and molecular background of inherited retinal diseases, and then we will describe the current journey of patients with inherited retinal diseases, trying to illustrate some challenges. And then we will move on to the opportunities by discussing the chance of referral those cases to an IRD specialist and the importance of genetic testing and gene therapy. So let's start with the clinical and molecular background. As you know, inherited retinal diseases represent a heterogeneous group of diseases that are caused by mutation in over 260 genes for retinal functions up to date. And the challenge is represented by the several levels of complexity, including locus and allelic heterogeneity with variable degree of expression. And therefore, the reporting the precise phenotype with the optimum genetic testing selection is very critical to confirm the clinical diagnosis and therefore to build up the genotype-phenotype correlation. So let us take around what are the common clinical features of inherited retinal diseases. Most of the time, you will see families at your clinic complaining of low vision, either at night or daytime, or complaining of photophobia. Sometimes they are complaining of nystagmus that is associated maybe with abnormal head position and eye wrapping. Some of them will also give a history of visual field construction, whether peripheral or central, and sometimes there will be a report of color vision defect. These symptoms can occur at any age of onset. Could be immediately after birth, shortly within a year of life, or maybe later on. So you will be, as a physician or clinician who will be assessing those families or patients, you will dictate in your history that these patients may complain of nyctalopia, photophobia, nystagmus with torticollis and oculodigital sign. If you opt to do a visual field testing, you will be able to notice visual field construction of either peripheral or central. If you move on to the ancillary testing, you will maybe doing fundoscopy or either by routine fundus exam, you will be able to see RPE pigmentation, some changes in the optic disc, like the disc which won't be healthy pink, but rather pale. The vessels won't be in a normal caliber, but rather attenuated. If you have the chance to do imaging, you will, such as fundus autofluorescence, you will see that these pictures will be reduced or absent. There will be, might be, or some area of hyper autofluorescence. If you have the chance to do full field ERG, the ERG might be reduced or diminished. So along of these signs and symptoms, you will be also to to determine whether the disease is isolated and the features are expressing mainly on the eye, or the disease is actually part of ongoing syndrome where other systems are involved and might be the eye symptoms is maybe the initial alarming sign. So for instance, the inherited retinal disease, if it's combined with bilateral sensory neuronal hearing loss, you might think of Usher syndrome. If the inherited retinal disease is combined by polydactyly, hepatomegaly, or diabetes, you might think of Bardet-Biedl syndrome. If the inherited retinal disease is combined by hepatomegaly, diabetes, you might think of Alström syndrome, and so on and so forth. The list is so long, but you should be able to consider whether the disease is isolated or syndromic. What happened that the majority of patients experiencing visual impairment due to undiagnosed inherited retinal disease, this will lead to multiple rounds of referrals and multidisciplinary services. And this is unfortunately what we see in a daily practice. We see families, patients rounding between hospitals or clinic or subspecialties without precise or definite answer about the diagnosis. Therefore, we want to give these families some hope. This hope might be represented initially by referring those cases to someone who is expert in inherited retinal diseases. So when to refer those cases? Whenever you suspect a family with low vision, as I mentioned, with night or daytime problem, with photophobia, is there documentation of nystagmus, visual field restriction, any abnormalities in the fundus pictures, including pigmentation, pale optic disc, visual attenuation, color defect, ERG diminished or non-recordable, isolated or syndromic cases, sporadic cases, or family history. At any age of onset, think of referral those cases to an IRD specialist. And why is that? Because the IRD specialist will take the case from scratch and will enable to dissect the disease, applying the principles of precision medicine, including the disease stratification and disease personalization. So the specialist simply will start with a detailed history, and this history would be as any history obtained in any subspecialty by general personal data, analysis of the chief complaint, the age of onset, the associated symptoms. But most importantly here is that we have to divide our history into three main compartments. These are the prenatal, birth, and postnatal history. And the importance of this is to avoid any chance of phenocopy or drug-related malformation or something else. Also notify or ask about systemic history and familial history. Once the IRD specialist will finish this detailed history, he or she will move on to summarize all this information in a one chart, what we call it family pedigree. And the aim of the family pedigree is to determine the mode of inheritance. As we know, we have so many forms of inheritance modes. We have the autosomal dominant, the recessive, and X-linked. Simply how we can draw a family pedigree. We can draw it like the female will be the circle, the square will be the male, and then we just put a bond between them to represent the relationship. If there is a consanguinity, then we can put a double bond, and then we can list here the offspring. Let's take them one by one. For the autosomal dominant, you will see that the transmission will be somehow vertical, and there is no difference between gender. Both male and female can be affected. As for the autosomal recessive, it's the same. Both female and male will be affected. There will be a higher chance of consanguinity. The parents will be carrier, and then the child, maybe one of them or two, will be affected, and another carrier will be there. The transmission in the autosomal recessive will be somehow horizontal. In comparison to the X-linked form, as we know, the males are only affected, and the females will be an obligate carrier. And the most important characteristic of X-linked is that there is no male-to-male transmission. So after obtaining the detailed history, then we have to draw the family pedigree to determine the mode of inheritance. Once we are done with these two important parts, we can move on to the routine clinical examination that we usually do in any ophthalmology case, including best-corrected visual acuity, slit lamp examination, fundoscopy, ancillary testing such as OCT, fundus autofluorescence. If you have the chance also to do the electrophysiology, field field ERG, visual field, then proceed with to have a complete picture of the case. And why is it important to follow this system? Because as I mentioned earlier, that inherited retinal diseases is considered as extremely heterogeneous disorder that can be presented with different phenotype, with different gene, with different mutations. So to build up a clear classification, we can maybe look at this chart. As you can see, inherited retinal diseases can be inherited in all mode of inheritance: autosomal dominant, recessive, X-linked, and mitochondrial. As I mentioned also in the detailed history, we have to insist about the age of onset, because the age of onset can give us a clue about the underlying disease course or the underlying diagnosis. So if the family report the night blindness less than 1 year shortly after birth, then think of Leber congenital amyloidosis. If it's between 1 to 5 years, then think of a severe early onset of cone rod dystrophy. Between 5 to 10, think of X-linked retinitis pigmentosa. And the second and fourth decade, think of retinitis pigmentosa or even macular disease such as Stargardt. But if it's presented more than 55 years, then you can consider the disease as an autoimmune. Then think or look at the pictures that you obtained or your fundus exam, where the defect exactly is presented. The defect is presented in the macula, precentral, posterior pole, mid-periphery, concentric, panretina. From maybe the OCT, where is the defect is particularly located? Is it at the RPE level? Is it in the choroid, choroidoretinal, retinal or retroretinal? And then based or from the history, think what is the most prominent photoreceptor may be affected? Is it rod cone dystrophy, cone rod dystrophy, or cone dystrophy mainly? As you know, we have two types of photoreceptors, the rods and cones. Both of them are evenly distributed all over the retina, where the number of rods are exceeding the number of cones by double. And the only part of the retina that is constituted mainly by the cones is the macula. Therefore, we have cone dystrophy, but we don't have rod dystrophy only. What we have is rod cone dystrophy or cone rod dystrophy, depending on which photoreceptor was the dominantly affected or starkly affected. Also from the history and examination, was there any other systemic involvement? Then think of other organelles may be affected. Maybe this is a ciliopathy, or maybe this is a mitochondrial disease, peroxisomal disease, lysosomal disease. And therefore, you can build your theory in maybe a syndromic form. As I mentioned before, it could be Usher, Bardet-Biedl, Jobert, Simulokian, Refsum, or Alcetron. Recently, or in 2017, Stone et al. Had built a nice classification actually to simplify the disease course, or how can we classify the disease in a simple manner. This is a large disease, a large group of disease, 260 genes, so many clinical entities. How can we group them maybe in one simple diagram? Look at this schematic presentation. So what did they do? They classify inherited retinal diseases into three main compartments. The first one is the photoreceptor, which constitute the majority of the cases, followed by macular disease, and then they call the third group as third branch disorders. If we look more deeply in the photoreceptor disease, you will see that retinitis pigmentosa constitute the majority of the cases, while in macular disease, the autosomal recessive Stargardt disease constitute the most component. And then in the third branch disorder, you will see other retinal disease entities like optic neuropathies, foveal hypoplasia, albinism-related retinopathies, retinoschisis, or choroidopathies. So simply, if we want to make a comparison between the photoreceptor and macular, so here we can put the rod cone dystrophy or cone rod dystrophy, but here we are talking mainly about cone dystrophy. As I showed you just briefly, the photoreceptor diseases represent almost 65% of the general group, while macular disease represents the 28% of the whole category. From the history, you can easily differentiate between these two entities, because in photoreceptor disease of rod cone dystrophy, patient will mostly complain of nyctalopia and constricted visual field, because as we know, rods are responsible for night vision. So this phenotype goes well with the affected photoreceptor. Vice versa, with the macular disease or with cone dystrophy, patient will come complaining of reduced central vision, color vision abnormalities, and sometimes variable degrees of photophobia and nystagmus. And why is that? Because cones are responsible for that. Our cones are responsible for central vision, for color vision, for precise vision. Also, another differentiation between photoreceptor and macular disease is the fundus appearance. What we see and what we usually receive from referral cases, the bone specule appearance, usually we call it typical RP or typical retinitis pigmentosa. So these bone specules, think of photoreceptor disease. But if you see like pisciform lesions, just white dots, maybe think of macular disease. On the other hand, if you opt or if you have the chance to do the full field DRG, the RG will be non-recordable in the photoreceptor because both rods and cones are affected, but the full field DRG will be somehow normal or better degree than photoreceptor disease with macular entity. So this is in short the main differences between photoreceptors and macular disease. So how can we differentiate again these entities or give genotype-phenotype correlation from clinical practice? As we know, this is the normal looking of the retina. And this is what we call it the typical RP or typical retinitis pigmentosa picture. That is represented by the pale optic disc, thin blood vessels, what we call it vessels attenuation. The vessels didn't look within a normal caliber. And you can appreciate these RPE pigmentation in the form of bone spicules pigmentation. So these are the bone spicules pigmentation. Most of the time we see these pigmentation mainly on the peripheral part or in the posterior part, but sometimes these typical presentation of bone spicules are accompanied also by a maculopathy, as you can see here in this picture. And in some literature, they found this might be a pathognomonic feature of RDH12 related retinopathies. If we move on, this is again the typical RP with the bone spicules, but sometimes the RPE pigmentation are rather nummular, circular in shape, as you can see here in this fundus picture, not the typical bone spicules. And again, in the literature, they found that this is somehow a pathognomonic feature for the CRP1 related retinopathies. This is the typical retinitis pigmentosa picture again, but this is another picture of patient with inherited retinal disease where the retina doesn't look normal. Well, we can describe it as mottling. There is no clear pigmentation, no white dots, and no bone spicules. So many clinical pictures or so many fundus appearance can be associated with inherited retinal phenotype. It's not mainly the bone spicules, as you just saw. It could be nummular, it could be mottling, it could be with maculopathy, it could be distributed all over, panretinal, it could be mainly in the posterior pole. So report or write these finding very precisely, because this will help you later on to build up your genotype-phenotype correlation, because without the effort of a previous scientist, clinician, we couldn't reach the moment to say this is a pathognomonic feature, for instance, for the CRP1 or other genes. So these pictures represented the photoreceptor disease. What about the macular disease? This is the photoreceptors with the dark RPE bone spicules, but with the macular diseases, we won't see such picture, but we would rather see kind of pesciform lesion, white dots distributed in the posterior pole, and most of the time there will be a macular lesion, there will be a maculopathy, and this will give you a hint or clue that you are dealing with a macular dystrophy case. So as of now, we have represented the maybe the challenges and somehow the opportunities of referring the cases to the IRD specialist. Because if you refer these cases to the IRD specialist, the physician will be able to request a genetic testing. So what is the importance of the genetic testing? As I mentioned earlier, the IRD represented by extremely heterogeneous allelic phenotypic variable expression. And this is represented clearly in this diagram. You can see that we have so many forms of inherited retinal diseases. We have here the congenital stationary night blindness, the LCA, the cone and cone rod dystrophy, the retinitis pigmentosa, Bardet-Biedl syndrome, Usher syndrome. So we have so many clinical entities, and inside each of bubble, we have several genes, and these genes can be also overlap between these two entities. So we have to solve that puzzle by requesting a genetic testing to achieve the precise clinical diagnosis, which won't be possible without requesting genetic testing. To request the genetic testing and to understand the importance of genetic testing, we also have to understand the pathophysiology of the inherited retinal diseases. As I just saw you in the previous diagram, a lot of genes are involved. And initially we have mentioned that there are more than 260 genes are involved and responsible for the pathophysiology of the IRD. This schematic diagram just summarized these genes or classified them based on what? Based on their role or function on the retinal process. Where are they expressed and what are their role in the retinal process? Are they part of the outer segment phagocytosis? Are they expressed in the retinal pigmented epithelium? Are they part of the visual cycle, phototransduction? Or maybe they are expressed in organelles like mitochondria, or it could be, or the cilia. It could be also part of the transcription factors that are important in the initial embryogenesis, or maybe in the synaptic process that are important to relay the message from the photoreceptor to the inner retina. So basically understanding the each gene function, site of expression, location, interaction will help you enough to understand the nature of the disease course, to predict the phenotype, and then later on you will be able to build a link in genotype-phenotype correlation and hopefully a treatment approach. And important of understanding the pathophysiology of these genes is represented now by the approved RPE65 gene therapy. As we know, recently the RPE65 gene therapy was the first gene therapy to be approved so far in the medicine or the precision medicine. So without understanding the gene expression function, they wouldn't be able to reach the moment to deliver that medicine to a real patient to change his or her life. So let's have a look where the RPE65 is located. So we have here the photoreceptor with a rod or cone, and we have here the RPE and the outer segment of the photoreceptor. And they found that the RPE65 is playing a role in the visual cycle. Where is it exactly? As we know, visual cycle or the vitamin A cycle is an important cycle for the photopigment regeneration. So the function of the RPE65 is to transfer the toxic material called 11-cis-retinal or all-cis-retinal with highly reactive aldehyde group. If it's mutated or disturbed, then there will be an accumulation of this toxic material with highly reactive aldehyde group, and this will lead to production of toxic bisphenol compounds known as lipofuscin. Now, what is the importance of this piece of information? The accumulation of lipofuscin as a result of RPE65 mutation. Actually, the lipofuscin are the bone spicule pigmentation that we see, the dark spots. So the amount of RPE or bone spicule pigmentation represent how the dystrophy is advanced or the disease course. So it gives you a hint. On another hand, if you proceed with the ancillary and request fundus autofluorescence, you will see that fundus autofluorescence with RPE65 will be somehow absent or reduced. And why is that? Because of the lack of isomerization of the previous step. And if you do the OCT, you will see the preserved foveal lamination, but the outer retinal and RPE atrophy will be presented parafoveal area. So all this information will help you later on to understand the disease course and to dissect the disease from clinical phenotype for each individual. So what we can conclude here is that the clinical diagnosis in the absence of genetic testing is considered as an incomplete diagnosis. Now, recently, the American Academy of Ophthalmology has listed the genetic testing as a crucial requirement for accurate and complete diagnosis of inherited retinal diseases. And why is that? Because simply this will enable us to pinpoint the cause of mutation and therefore to direct the disease management, to define the prognosis, to inform genetic counseling and family planning, and indeed to identify those for whom gene-based or other therapies might be appropriate. To achieve this step, one hand won't be enough, so we need to have a competent team, including IRD specialists, molecular geneticists, clinical scientists, bioinformatician, genetic counselor. All these have put at their disposal to help the patient and families to reach out to a successful moment of reaching the precise diagnosis, the right track for family planning, maybe the right track of prevention or production, and the hope for maybe gene therapy based in the near future. So how can we select the genetic testing? Now, the genetic testing option or the selection of appropriate genetic testing is another skill. But simply, we have so many options. We have the single gene screening. We have the gene panels that are grouped by clinical diagnosis. We have the whole exome sequencing and whole genome sequencing. Now, for the single gene sequencing, we used a technique called Sanger sequencing, in which, in a single experiment, we sequence a single gene. Now, we are talking about inherited retinal diseases that are caused by more than 260 genes. So, would single gene testing would be an option to request for a patient with suspected IRD? This question could be answered as yes, and also no. If you have enough expert to decide that you are sure about the clinical diagnosis, let's say you are in front of a family that are presented with a macular dystrophy form of a Stargardt disease, and you know in advance that the Stargardt disease is caused by ABCA4 gene, then it would be a good option, fast and also cost effective, to request just a single gene testing for that particular gene. But if you are dealing with a kid that is who or she is complaining of nystagmus, night of blindness, maybe with some sort of systemic involvement, so you are not sure, you are hesitant, what is the definitive clinical diagnosis here? You're sure that you are dealing with an inherited retinal disease, but at this level, you are not sure to say this is a real cone dystrophy or rod cone dystrophy or retinitis pigmentosa or congenital stationary night of blindness. Then in this case, we have to proceed to the next generation sequencing technique, in which they have so many options, either the gene panel that is grouped by the clinical diagnosis, the whole exome sequencing, where we sequence the entire exome of our body, which is approximately the 20,000 coding protein gene, or we go advanced and do the whole genome sequencing that's including both exome and non-exome, the non-coding part, so our entire genome. Now, from clinical point of view, most of the literature and most of the centers have found that gene panels that are grouped by clinical diagnosis is a first-line approach, very fast, very predictive, specific, but there are some limitations. If you go with the gene panel, you might get a negative report that is not truly negative, because you were only searching within a bubble. You don't have, or you didn't expand your technique to identify maybe a novel gene. With whole exome sequencing, you will have that luxury, but then the amount of data that is needed to be filtered would require further time, efforts, and manpower. So depending on the maybe agreement in your hospital, I'm sure we all face a challenge in choosing the right genetic testing option. And sometimes not because of lack of expertise, but because of lack of the agreement with the lab or the available gene center at your hospital or in our country. Because sometimes I really want to order single gene testing because I'm pretty sure about the diagnosis, but I don't have the facility, then I will go rather for panel or exome sequencing. But in short, these are the differences. So whenever you have the chance to choose, think of your options before you order, to save money, to save time, and to reach the precise diagnosis within a time frame that is required to achieve the diagnosis correctly. Once you choose the best tool to go with the genetic testing, then you should be able also to read the genetic report, because now we are talking about clinical cases, diagnosis, maybe future family planning or therapy approach. Then you have to be 100% sure about the results that you will be reporting to the family. Therefore, you should be dealing with a trusted or certified labs that of either CAB accredited or ISO certified lab. Most of these labs nowadays are applying the ACMG, which is the American College of Medical Genetics variant classification. Simply, they are 5 classes. So whenever you have the report, you will find the gene name and the mutation, where is it located exactly, and the class. Now, look at the class in your report. What is the number of that class? Is it 1, 2, 3, 4, or 5? Okay, what are the meaning of these numbers? If it's 1 or 2, meaning that you are dealing with the benign zone. If it's 1, this is just a benign variant, so you can easily ignore it, don't report it, likely benign somehow also within the same caliper. Then if the reported variant is a class 4 or 5, then put a red flag and read your report carefully, because class 4 is likely pathogenic. It can be reported. Be precise, try to build your genotype-phenotype correlation. And class 5 is really pathogenic variant that can be reported again. In each way, you need to build up the genotype-phenotype correlation. Now, the challenge is always with the class 3, which is the variant of unknown significance. You have a report with a clear phenotype, and the genetic testing is reporting a mutation or a variant of a class 3 in a certain gene. So what will you tell the family? Okay, we have found a variant with a gene within a gene, but we are not sure whether this variant is really disease causing or just benign and you can just ignore it. And the challenge here can be solved with an extra level of expertise. How would you deal with this inconclusive data? Because this would require another effort of research collaboration, search in other data sets or databases, look for in silico production, do segregation testing, because sometimes this will help you also to increase the caliper of class 3 to class 4 or maybe even 5 if you obtain good results. Now, another challenge of reading the genetic testing is that genetic testing reports are are not easy and simple to be read and to be reported as any lab results like CPC or others. These results require really a level of expertise, very careful mindset, with careful reading to review again, what have you requested? What did you write in that report? What is the age? What is the age of onset? What is the chief complaint? What did you order? Did you order a gene panel, whole exome, or whole genome? What are the results? Do you have, which class is the variant? Where are they located? Are they codon or non-codon? If you have inconclusive results like variant of unknown significance, as I just explained, do your efforts to solve the puzzle, whether the report is dealing with a benign case or with a pathogenic case. Sometimes, if you know that the disease course or the disease is inherited in an autosomal recessive manner, then you should be able to know that in that report, the variants should be either homozygous, meaning that 2 copies of that gene are affected, of either homozygous or compound heterozygous. So if the report is illustrating only heterozygous variant, only 1 copy of the variant is identified, then you need another effort to solve the missing heritability. Where is the second allele? Was it missed by the technique because I requested something that is not covering the whole region? Do I have to expand my molecular technique? Or I just order a panel and then the case is still negative, or only one variant, then maybe a novel finding could be still a chance, but I need also to expand my molecular technique to go with the whole exome or whole genome, or sometimes to knock the door in the non-coding part of the genome. Another challenge with the genetic testing interpretation is that when you go for a whole exome sequencing or whole genome sequencing, that there will be a chance to identify a secondary finding or incidental finding. What are they? These findings. Simply, the family in front of you came with the main complaint of night-blindness, and you have requested for them a whole exome sequencing. The report came with a table saying that these are secondary or incidental findings. And in that table may be a mutation in BRCA gene, as was identified of a class 4, which is really pathogenic. As we know, BRCA gene is related with the breast cancer. So this is a life-threatening condition. This is a red flag scenario. In this case, one-man show is not sufficient. You cannot report that incidental finding immediately to the family. A committee should be assigned. They should discuss how to report this piece of information to the family, because in another country, like for instance in Europe, they have the right to choose whether they want to be informed about these incidental findings or just ignored. I came for an eye problem, so I don't know. I don't want to know anything else. In another country, no, there is no privilege to choose. Then you have to be informed if it's really life-threatening. But again, it's not a one-man show. It needs to be assigned as a committee, and then to deliver this bad news, to refer that patient to the right track to save her or to save her life in case of a BRCA gene, for instance. So now we have summarized the selection of genetic testing, the importance of genetic testing, how we read the genetic report, and how we should interpret these reports if there is a chance of if there are inconclusive results or incidental finding. So let's now move to our 4th objective, which is gene therapy. And why the eye is an ideal site for gene therapy. So once you are sure about the disease causing gene, then eye is an ideal site for gene therapy. Why is that? Because our eyes are very small, so they are requiring a small amount of vectors. They are accessible, they're immune privileged with the blood retinal barrier. The ability to visualize the vector delivery, whether whether within a surgery or to follow up the progress after surgery with the non-invasive techniques like imaging, for instance. So all these caused our eyes an ideal site to go for gene therapy. But remember, gene therapy itself, it's not a one-size-fits-all treatment approach, but rather a number of highly diverse technologies. And these technologies will depend again on the disease course itself and the mode of inheritance and the role of gene and the mechanism. What is it exactly? Most of the time, if we talk about autosomal recessive diseases, then the disease will be caused by missing or disabled protein caused by mutation in 2 copies. So the 2 copies will be defected, the gene won't be working properly, then we have a loss of function. In that approach, we can think of gene augmentation. And this is the approach that was applied with the RPE65, for instance. For the RPE65 gene therapy, they understood that the disease course with the RP or with the LCA is an autosomal recessive. It's caused by mutation in RPE65, where we need a biallelic mutation, meaning that we have to have both affected alleles or both affected copies. So the whole gene is not working. Therefore, how can we treat? We augment. We give a normal copy that can replace the defected copy. How can we deliver that normal copy to the eye? This requires a transporter. We need a vector. Most of the time nowadays, they are using viral vectors, like adeno-associated viral vectors, and depending on the site of the gene, whether we use with the adenovirus or if it's a small gene or if it's a large gene like Stargardt disease with the ABCA4, then we can go with the lentil virus. Where can we inject or augment that piece of information or the new gene, depending on, again, on the location of the gene. So for the RPE65, the injection was subretinal injection because as I showed you earlier, the gene was expressed in the outer segment of the photoreceptor. So this is the ideal site where we can put the gene and restore its function. We have other mode of or technologies of gene therapy, as I mentioned, depending on the disease course, the mode of inheritance. We have one tool called gene editing. It's a hot topic nowadays in genetic. They call it CRISPR, with the CRISPR-Cas9 technique, where they can correct the genetic coding of the protein within the target cell using this technique by gene editing. Another technique called antisense oligonucleotide, where they can stop production of a harmful mutant protein by preventing the translation of messenger RNA, the RNA transcript, or to correct abnormal intron splicing site in a mature messenger RNA. This is most of the time applied in where if the mutation is located in the splice site, and this is now a hot topic in preclinical trials for CEP290 related LCA or retinitis pigmentosa. They worked on antisense oligonucleotide, and I think they reached a good stage in the clinical trial phases. Again, the mode of administration will depend on the site and of gene expression and localization. So nowadays, they can choose between subretinal injection or intravitreal injection. As you know, for the subretinal injection, this is an OR procedure that requires vitrectomy, while intravitreal injection, this is a normal procedures done routinely by a retina specialist in the outpatient clinic setting, where they inject for instance, the anti-VEGF for diabetic patients and so on and so forth. Therefore, gene therapy, it's not a one-size-fits-all treatment, but rather a number of highly diverse technologies. And one of the promising and huge landmark in the gene therapy was the approval RPE65 gene therapy that was obtained initially in US in 2017, followed by Europe in 2018. And luckily, we have reached the moment to apply this advanced gene therapy treatment in our country between 2019 and 2020 in a Saudi patient, which make a huge milestone in ophthalmic genetic path in our country. So for the RPE65 gene therapy approach, this schematic diagram summarizes how can we select patients for RPE65 gene therapy. This is a recent article published in 2021, in which they summarize as follows. If you have a case with a suspected inherited retinal disease, assuming that you are a pediatrician, general ophthalmologist, medical geneticist, whoever, then refer that case to an IRD specialist to obtain the precise diagnosis. As I illustrated earlier, obtain the detailed history, document the exact sign and symptoms, whether a patient was complaining of night blindness, reduced visual acuity construction of the visual field, proceed with your clinical examination of visual acuity, ocular fundus photos, ERG, visual field, and define your phenotype, whether you are dealing with an LCA with an age of onset is less than 1 year of retinitis pigmentosa or early onset retinitis pigmentosa, and then order the precise genetic testing. Make sure that RPE65 is involved in your list. So if you opt to go for a gene panel that is grouped by clinical phenotype or a clinical entity, then make sure that RPE65 is included in that panel. Otherwise, you will miss it. If not, then maybe you can request whole exome sequencing. So depending on the facility at your center. Once you have chosen the correct or the precise genetic testing tool that is included the RPE65, as I mentioned, panels are highly appreciated in the clinical setting. They are using it as a first approach. Then confirm or proceed with the segregation. Segregation is a very crucial component in the procedure of gene therapy, because we want really to make 100% sure that this is the disease causing the mutation. If yes, then proceed to the next. If it's not segregated within the family members, then we won't consider this patient as an eligible for RPE65. Again, these tests should be done in a certified lab, not in any lab or any research context genetic testing. It has to be a certified lab with a CAB or ISO accredited lab. Then, as I mentioned, once you are sure you have done your segregation, you are sure this is a biallelic RPE65 mutations of either class 4 or class 5, not a variant of a non-significant, not benign, so it has to be 4 or 5 class. Then the decision of administration of RPE65 gene therapy will depend on another level of expertise that can be answered by the retina surgeon. Is there a viable retinal cells by OCT, visual field, visual acuity? If yes, again, proceed with the baseline ophthalmological examination, discuss the surgery plan, and proceed with the eligibility. If there is no viable retinal cells, then again, this candidate is not eligible to proceed with RPE65 gene therapy. So choosing the right patient is another journey that require a lot of efforts before. So having a patient with positive RPE65 is not sufficient to say, I have a candidate for RPE65 gene therapy. It has to go through all these processes to reach the moment that, okay, we can administer this gene therapy to that particular patient. So RPE65 gene therapy is a good example to represent precision medicine in ophthalmology. And how is that? Because with RPE65 gene therapy, we were able to apply the 3 rights: the right patient, the right intervention, and the right time. What is the meaning of that? The right patient, meaning that patient with an age of 3 years or above, confirmed clinical diagnosis of retinitis pigmentosa or LCA, biallelic RPE65 mutation, confirmed segregation, absence fundus autofluorescence, and non-recordable ERG. So you're done with this list. Then the right timing, the decision about the viable retinal cells. Recent publications has mentioned that the criteria for viable retinal cells are listed as follow: visual acuity of 20/60 or worse, less than 20 degrees of residual Goldman visual field in any meridian, sufficient retinal cells viability defined as an area of retina within the posterior pole of more than 100 micron thickness by the means of OCT, and of course the right intervention with the route of administration by subretinal injection of 0.3 ml of each eye separately within close interval no fewer than 6 days apart. So RPE65 gene therapy has opened the gate for precision medicine to apply in the field of ophthalmic genetics, but it's, as I mentioned, we are dealing with a heterogeneous group of disease caused by more than 260 genes. So how can we give our patients a hope? We can tell them that ocular gene therapy is very promising and emerging field with the potential to treat both rare inherited retinal diseases and more common acquired retinal conditions nowadays, such as age-related macular dystrophy. If we check the recent pipeline, this is also a recent publication in 2021, in which they summarize the ongoing clinical trials for several forms of inherited retinal diseases. As you can see here in this table, we have for instance, the achromatopsia, how many clinical trials, in which phase, what is the target gene, what is the mechanism, what is the current status, if it's recruiting completed or just stopped for any reason, and so on and so forth. Here you have the X-linked retinoschisis, the X-linked retinitis pigmentosa, autosomal retinitis pigmentosa, choroideremia. As you can see here in the choroideremia, they have even reached the stage 3 clinical trial. And I believe this is about to be announced very soon. And the only one that is approved is the LCA2, the autosomal recessive RP, represented by the RPE65 gene therapy with the adeno-associated viral vector type 2 that was applied by Spark Therapeutics. This is again the continuation of the same list with the Stargardt disease, with Usher syndrome type 1B, Usher syndrome type 2, retinitis pigmentosa, LCA type 10 with the CYP290, as I mentioned earlier, with the antisense oligonucleotide approach. They are reaching now the second phase. They are still recruiting. So these were the gene therapy approach. Again, in this table, other approach other than gene therapy, such as optogenetic, antioxidant neuroprotection, stem cell, and cell-based therapies are also included in their summary review. If you want to check the current status of clinical trial for any gene, then I would definitely advise you to go to this website to search for the disease entity or for gene by gene itself, and then you will be able to know more information about that particular disease or gene status. So after all these, remember, since gene therapy is delivered to specific target cells and not to reproductive cells, the resulting changes cannot be passed to the offspring. Therefore, as I always insist, we have to start the wheel from the beginning to apply the prevention, the early detection, before even reaching the checking the mutation or targeting some patient for gene therapy. Because we opt to reach this ideal journey for our patients with inherited retinal diseases. I hope we can serve our patient with inherited retinal disease with the optimum ophthalmological assessment, detailed medical assessment if they need, if there is any sort of systemic involvement, then we have the chance to obtain their blood, their consent to proceed with the genetic testing approach, whether single gene, whole exome, whole genome, or even mitochondrial panels, and then to be able to genetically counsel that family in a proper way. What is their need at that moment? Is it a family planning? Is it a production? Is it really treatment? Where we are on that treatment approach? What is the current stage of that particular gene? Is it listed in the clinical trial? If yes, what is the stage, which phase? This just take the detailed history piece of information precisely, step by step, to reach out to the moment where you have more or less a complete picture about genotype and phenotype. Because it's not all about therapy nowadays. Although therapy gives us a huge hope and make a huge milestone in our career path, but as I mentioned, prevention, early detection are very important also, because as we just saw, that gene therapy is treating only the affected patient, and that affected patient might still have the chance to spread the mutation to his or her offspring. So spreading the awareness is very crucial, very important. Since gene therapy is applied to specific target cells and not to reproductive cells, the resulting changes cannot be changed to offspring. Remember this message. And with this, I can conclude our session. And thank you so much for your attendance. And we can open the floor now for the discussion.
Thank you, Dr. Basamat, for this nice illustrated lecture and presentation, and to give us a roadmap on how to deal with this patient and these cases, and to know what is expected for them and how to deal with them. I remember Dr. Arif Khan, who's our mentor and known to almost all of us. He used to say, I don't feel relaxed till I know which gene is the cause of this retinal dystrophy in this patient. Because sometimes, as you said, some disease, they have syndromatic issues, and they may be at risk for their life by not diagnosing the gene that's affected, not only for the treatment issue. We'll have some questions from the attendees. Do we have to test the patient with retinitis pigmentosa who's at older age, like 30s or 40s, to do genetic testing?
This is a very nice question. Now, again, I will emphasize on the importance of the gene testing. Now I am in the clinic, I'm in front of this patient who is 30 or 40, then I will go back to the history step. I will obtain the detailed history. What was the age of onset of that patient? Was it presented now in his 3rd, 4th decade, or was it presented earlier, but he just came for the consultation now? So depending on the age of onset, the disease course, I can decide to proceed with the genetic testing. Although if he's still 30 or 40, I will just still put him or her in the category of inherited retinal diseases. Then again, depending on the history, the clinical finding, I will be able to decide to order the genetic testing for him, or maybe from the family pedigree, is there an affected offspring? Then maybe I'll start with the younger generation, because still we have limitation in genetic testing. So whenever I have the money and chance to sponsor a genetic testing for a patient, I would rather help a young child to solve the puzzle earlier than elder stage.
Yeah, this may help even with the family planning.
Definitely, definitely, yes.
Another doctor attendee is asking where to refer the patient who arrived to their hospitals for this genetic testing if they need it.
Well, again, this is a very good question. Now, I believe the number of IRD specialists is quite rare in the worldwide, not only in our country. We and myself and our colleague in the field are doing a tremendous effort to support each other, to discuss the cases, to accept the cases. Until now, unfortunately, we don't have a clear system of referral for such cases. If you are talking about about the Ministry of Health or military hospitals. But I can now personally talk about our experience in the King Saud University. We recently have launched a specific clinic for retinal dystrophies, where I received the cases or the referrals from my colleagues and the other specialties, whether retina, pediatric, anterior segment, whatever the complaint is. We have eligibility committee, so they discuss the case. If the case is eligible, then they refer that particular patient to my clinic, and then I can see that family and help them to sort out what is the underlying genetic defect. Indeed, we need to invest more effort in this system to avoid this round of referrals without a clear answer. I hope one day there will be a clear track for all the patients that tackle all these sectors, the private and the Ministry of Health and even the university hospitals.
Yeah, especially the anticipated approval of further medication that can help to diagnose these cases.
Yeah.
I have a question. If you have a report of class 3 mutation, can testing the other family members help in knowing that if this gene is or this mutation is pathogenic of the condition or not? Maybe it's basic.
Definitely, segregation is very crucial, very important in any step of genetic confirmation. But again, if I would segregate this disease causing variant with the class 3 variant of unknown significant in another family members who are not affected and found to be present, this will give me clue that this is a benign, because that patient, that particular member was carrying for this variant and he is not complaining of any symptoms. So this will exclude the chance of pathognomonity, let's say.
Great. I didn't see further question. Thank you very much. It's 9 o'clock now. It's been enjoyable 1 hour really to listen to you, Dr. Basamat, for this presentation. Thank you.
Thank you so much, Dr. Mohammed, for organizing this webinar, and thanks for all the attendees for sitting with us for this 1 hour. I hope it was enjoyable and informative. Thank you all, and have a good evening.
Thank you very much. For the SOS members, I will leave you with Ms. Nikata from IQVIA HCP space, who gave us the platform for this presentation to give short presentation about this platform and how it can be beneficial to members of SOS. So I leave you with her, and thank you very much for listening to us.
So hello everyone, a very warm welcome to every one of you. I hope you all are doing well. So let me give you a brief on IQVIA HCP space and how does this platform works. Okay, so going forward, IQVIA HCP space is a unique networking platform exclusively for healthcare professionals. More than 60,000 healthcare professionals from Africa, Middle East, and South Asia have joined the platform. 17 reputed medical associations have also joined the platforms. HCP space unites specialties, subspecialties of doctors, pharmacists, nurses, medical laboratory scientists, as well as other healthcare professionals within an exclusive password protected on mobile app or on desktop. In addition to interesting webinars like this, HCP space allows physicians to network with physicians from across the globe, access e-learning courses and earn CME points, create cases and discuss it with peers. So register today on HCP space on your computer to search for HCP space app on your mobile phone. So let us see the video so you would get the more adept knowledge to it, how to get hand to it. Murthy, can we have the video, please?